Hi, my name is Katie Connor. I've been working in PA education for about 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. Today, we're going to talk about our hematology objectives. This is part of our 13-part series to help didactic gear let it be a little bit easier and help you ace your board. So let's look at our objectives for this unit. We'll be talking about multiple different types of anemia, our coagulation disorders, and then we'll end off with our malignancies. Before we get started, I just want to kind of help you simplify and compartmentalize a lot of these labs. This unit is very heavy on labs. So if you understand why we're ordering it, that way we're not just memorizing it per disease. So let's start off with a blood smear. This is where we take a sample of blood and look at it on a microscope slide. This will help us to identify characteristics of the red blood cells. So their shapes, specifically things like sickle cells, spherical cells, target cells. There's a lot of different shapes that are specific that we're looking for on this one. It'll also tell us how big or small they are. Then we have the CBC with differential, by far the most commonly ordered lab for this unit. It's fast, it's cheap, it's easy, and it gives us a lot of good information. So this will tell us our different types of cells, including our red blood cells, our platelets, our hemoglobin and hematocrit, and then the different types of white blood cells. This is one of my favorite mnemonics. Never let my engine blow. 60-30-830. This tells you the normal percentages of distribution for our neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Then we have a coagulation panel, which tells us how efficiently is this patient clotting. It will look at bleeding time. It will look at prothrombin time, or PT, and that measures our extrinsic pathway. We'll look at INR for patients who are on warfarin because we want to keep them in a target range for efficacy. Partial thromboplastin time, or PTT, helps us measure our intrinsic pathway. Then we have the hemoglobin electrophoresis, and this helps us to look at some of our genetic disorders. So if we suspect that there's a genetic disorder going on here, we can order this to help identify things like sickle cell anemia and thalassemia. Iron studies are going to be specific to our iron deficiency anemia. So TIBC, or total iron binding capacity, is also called transferrin. I want you to think about this one like seats on the bus. If we have a lot of seats available, that means they're not being filled with the iron. So in somebody who has an iron deficiency anemia, they're going to have a lot of seats available on their bus. So your TIBC will always be elevated if you have an iron deficiency anemia. Serum iron is what the iron is in the bloodstream, and then our ferritin is our stored iron. Both the serum iron and the ferritin will be decreased if we have a patient with iron deficiency anemia. Free haptoglobin. This is kind of the taxi cab that transports all of the little hemoglobin around the bloodstream from our lysed red blood cells. So if we have a hemolysis or a hemolytic type of anemia, pew, 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 those are all exploding everywhere. The free haptoglobin comes along and picks up that hemoglobin and transports it around the bloodstream. So if you have hemolysis, you will have a decreased free haptoglobin because it's being used up. Lactase dehydrogenase, or LDH, this indicates that there's a cellular damage going on. So in the case of hemolytic anemia, pew, 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 they're all exploding. That is indicative of cell damage. So your LDH will always be increased in a hemolytic type of anemia. We have the indirect Coombs test. This indicates the Rh status of a pregnant mother and her fetus. And then finally, the direct Coombs test. This will be positive in any autoimmune type of anemia where we have antibodies to the red blood cells. And a good example of this would be lupus. A lot of the anemia history and physical are very similar, meaning they are not just specific to one of the anemia. This kind of one or the other of the anemias. This kind of shows you the spectrum going from mild anemia to very severe anemia of what those patients should go through. This is highly dependent on A, the severity of the anemia, and B, the overall health status and age of that patient. So if we have a mild anemia, one of the first presenting complaints would be fatigue. Then we go on for weakness, dizziness, orthostatic hypotension. They stand up and they get really lightheaded. Tachycardia, because the heart is beating faster in order to try to drop off the oxygen at the tissues because we don't have enough red blood cells. Pallor, they look very pale, shortness of breath. Angina indicates ischemia or lack of blood flow to the cardiac tissue. then syncope, and then finally AMI, or acute myocardial infarction. This is not just ischemia now, but it's infarction. There's not enough oxygen getting to the tissues, so they're starting to die off. So that just ranges mild to severe, what we may see in the history and physical of these anemia. Let's talk about the life cycle of bilirubin. It's important to understand this because this unit has a lot to do with the life cycle of the red blood cell. We will also review this one again when we get into our GI unit because it's important for that one too. In a normal healthy person, the lifespan of a red blood cell is about 120 days. Then it gets chewed up by the spleen and that will release heme. Heme is then converted with heme oxygenase and it becomes unconjugated bilirubin. Keep in mind that unconjugated bilirubin is not water soluble. Unconjugated bilirubin will be transported through the bloodstream by albumin, and the albumin will take that unconjugated bilirubin to the liver. This is the site of conversion from unconjugated bilirubin to conjugated bilirubin. UDP is a chemical that's about 25 letters long that helps us to conjugate that bilirubin. And here's the big difference is now that conjugated bilirubin is water soluble. So now we can get rid of it in the body. And there's 3 ways that we really utilize that conjugated bilirubin. It is stored in the gallbladder. The first thing we do is get rid of it through feces. So it becomes converted to urobilinogen in the intestines, and then it is excreted through the feces in stericobile. That's what gives our feces those dark colorations, that brown coloration. Next, we're looking at the renal system here. So we have that urobilinogen is processed by the kidneys, and then it's removed from the body in the form of urine. So urobilin, and that's what gives our urine that kind of yellowish coloration. And then finally, whatever's left is recycled through the bloodstream in the form of urobilinogen through the portal blood system, and then it goes into making new red blood cells. So that's the overall lifespan of the bilirubin, how we get rid of it and how we convert it. Next, let's talk about our types of anemias. And I want you to categorize these in what is making them up. So our microcytic hypochromic anemia, that's going to be our small pale cells. In this, our factory is normal. So our bone marrow is normal. That's circled in green. It's working just fine. The problem with these anemias is that they have a deficiency in red blood cell building blocks. So our 3 different types of our microcytic hypochromic anemias are going to be thalassemia, iron deficiency anemia, and sideroblastic anemia. Next, we have normocytic anemia. Our factory is broken. It's not working up to maximum capacity. So we have a defective bone marrow, and that's causing our red blood cells to be deficient. It can't produce enough for what we need. Examples of this would be our aplastic anemia, our anemia of chronic diseases, and then our myelodysplastic syndromes. Next, we have our macrocytic or our large cell anemia. This is going to be where the bone marrow is normal, so our factory is working just fine, but we have a deficiency in vitamins that make up the red blood cell. Our 3 types that we'll talk about for this are going to be B12 deficiency anemia, folate deficiency anemia, and then anemia of chronic alcoholism. Our final type of anemia is hemolytic. So our factory works just fine. The bone marrow is working just fine, except we have fireworks all over the place because this is a hemolytic. Boom, boom, boom. The red blood cells are exploding everywhere. That's what's causing the deficiency in numbers. And there's quite a few in that list there that we'll get to today. Let's talk about the special cells that we may find on the smear. And you may see these present in the question that they're trying to give you more information on what this disease could be that they're asking you about. So first, we'll start with the Howell-Jolly body. We see this in patients who have an absent or a damaged spleen or any of our megaloblastic anemias. So common examples of that would be our myelodysplastic syndromes, sickle cell, thalassemia, B12 and folate deficiency anemias. Then we have a target cell or a codocyte. What happens here is that there's a decreased level of hemoglobin, so it makes the red blood cell kind of wrinkly. We'll see this in thalassemias, iron deficiency anemias, and sickle cell anemia. Dacryocyte or a dacrocyte, same thing. This is bone marrow fibrosis is what causes these cells. So we see these in our leukemias and our myelodysplastic syndromes. Next, we have our schistocytes. These are little fragments of red blood cells that occur as they're traveling through clots. So a lot of our clotting disorders, we see these. So DIC, TTP, and HUS, which we'll get into in this lecture. Next, we have our smudge cells or our basket cells. As they're doing the smear, these cells are so fragile that it actually breaks or smudges the cell. And we see this in our CLL, or chronic lymphocytic leukemia. And we'll get to that when we get to our last part. Basophilic stippling is a result. It's little basophilic granules that are aggregated ribosomes that kind of form these sprinkles in the erythrocytes. And you can see that arrow pointing to that one there. This is most commonly associated with thalassemia, but can also be present in iron deficiency anemia and lead poisoning. So those are our different types of cells that you'll commonly see in the exam questions. Next, let's talk about the workup for anemia. How in the heck do we know when to order these labs, when to not order these labs? This is kind of an easy algorithm. So if you suspect the patient has anemia based on those history exam findings, history and physical exam findings that we discussed on that kind of pyramid, then we're going to order our first test, which will be our CBC with differential. If the CBC with differential comes back to be normal, so we have a hemoglobin over 13 or hematocrit over 42, they don't have anemia, and we can cross that off our differential list. If their CBC comes back and there is anemia, so we have a hemoglobin under 13 or hematocrit under 42, then we have to start thinking about, okay, how do we sort out what this anemia could be? Let's look at our red blood cell indices. These tell us how dark or how pale, how big or how small those red blood cells are. So if we start out with a normal red blood cell, so our MCV, mean corpuscular volume, what's the size? If the size of this is normal, we need to start thinking about, remember, this is the one where the factory's broken and it's not making enough red blood cells. So bone marrow biopsy, looking for our myelodysplastic syndromes, or renal function. We could look at our BU endocreatinine because this can be associated with chronic renal failure. Let's say it comes back and it's a macrocytic anemia or a large cell. We'll have an elevated MCV. We're going to be looking at our serum B12, our serum folate, and our liver function test because this can be associated with chronic alcoholism. Next, let's say it comes back and it's a microcytic hypochromic. So it's a decreased MCV, and then it's a decreased MCHC, mean corpuscular hemoglobin concentration. So it's going to be kind of pale. The first test we're going to order is iron studies because that's by far the most common anemia that's a microcytic hypochromic. In iron deficiency anemia, like we talked about, the TIBC, remember the seats on the bus, will be elevated. Our serum ferritin and our serum iron will both be low. Then we got to figure out where could this possibly be coming from. With iron deficiency anemia, a common cause of this could be GI bleeding, so GI cancer. So we would order a hemocult and a colonoscopy. It could also be coming from heavy menses, so fibroids can cause this. So you could order a pelvic ultrasound. And then finally, early on in pregnancy, iron deficiency anemia is very common. So if it's a woman of reproductive age, you could consider getting a beta-HCG test. If the iron studies are normal, then we have to think about other things that could be causing this. So we could order a hemoglobin electrophoresis looking for things like thalassemias, or a serum heavy metals, which would be Citroblastic. That's most commonly caused by lead poisoning. So this is kind of the workup and the algorithm of how to go from a CBC to figure out exactly what anemia is being caused here. Let's get into the meat and potatoes now of the objective. So remember, in our microcytic hypochromic anemias, our factory is working, but we have a deficiency in the red blood cells. So we'll talk about thalassemia, iron deficiency anemia, and sideroblastic anemia. So let's start off with our thalassemias. There's several different types of thalassemia. The two kind of umbrella categories are going to be alpha and beta, and there's different types within each of those. The most common history is going to be prolonged jaundice, but it can also be associated with mental retardation. In the physical exam finding, it's very common in these to have bony deformities. So they may have an enlarged forehead, frontal bossing, we call that, but there's lots of bony deformities that are associated with both of these thalassemias. Alpha thalassemia is caused by a defect in chromosome 16, and there's 3 different types of this. Alpha thalassemia trait is where you have 2 normal and 2 defective alpha globin genes, and this will cause a mild anemia. Hemoglobin H disease is where you have 3 defective alpha globin genes, and this causes a moderate hemolysis. And then finally, you have alpha thalassemia major. This is 4 defective alpha globin genes. This causes severe hemolysis and edema, That's called a hydrops fetalis, and all of these die in utero because this is incompatible with life. In beta thalassemia, this is a defect in chromosome 11. We have beta thalassemia minor and beta thalassemia major. In minor, one of the beta chains is defective. This will cause a mild type of anemia. In major, both of those beta chains are defective, and this will cause a severe hemolysis. So remember that both of the majors cause severe hemolysis. This is most common in our ethnicities of African, Asian, Mediterranean, and Middle Eastern populations. Let's go through the labs. Remember, this unit is lab heavy. So on CBC, we know that this is going to be a microcytic hypochromic. So we'll have a decreased MCV, decreased MCHC, and an increase in reticulocytes. Reticulocytes are little baby red blood cells. So the body's trying to kind of compensate by making more red blood cells. On our smear, remember, this gives us our shape. So a microcytic, hypochromic. We may also see these special types of cells, the target cells, basophilic stippling, anesopellicocytosis, which means that the cells vary in size and shape. The definitive test for thalassemia, so the correct answer on your test is going to be a hemoglobin electrophoresis, because remember, this is a genetic type of anemia. Chromosome 16, chromosome 11 will be defective in the alpha and beta respectively. The treatment for both of these is chronic transfusions. You can try a stem cell transplant and then a splenectomy, because the spleen is working kind of overtime and we don't want it chewing up so many red blood cells. So those are your thalassemias. Iron deficiency anemia is one of the most tested concepts on the boards for the hematology unit. In iron deficiency, there's a lot of history and physical exam findings that are pretty specific. So ice cravings, pica is where the person will crave clay or starch because their body is craving that mineral. They tire easily. They may have heavy menses. That could be the cause of this. Claudication, where they get kind of pain in their calf muscles as they're working because they're not getting enough oxygen to that muscle. Poor dietary intake could be causing this. Cold intolerance. Low child IQ. This has a function neurologically. Melena, if it's a GI bleed that could be causing this, and dysphagia. After a while, you can develop something called a Plummer-Vinson web, and that can cause trouble swallowing. Glossitis, spoon-shaped nails. Look at that top picture there, they have this kind of spoon shape to the nails. That's called colonychia. Angular cheilitis, you can see in the second picture down there. Now we know angular cheilitis could also be candidiasis in that area if they're chronically wet in the corner of their mouths. Plummer-Vinson esophageal web, that's an important one. Plummer-Vinson esophageal web, that's the bottom picture there. That is something that is specifically associated with prolonged iron deficiency anemia. And you can imagine if the patient has that, they would have trouble swallowing. The causes of iron deficiency anemia. Blood loss is a very common cause for this. Hookworms. These used to be a common cause in the South in the early 1900s because people would walk around in the fields and, when they're harvesting their crops, and a lot of animals would defecate in that area. So they would absorb hookworms through their skin. Hookworms bury into the intestines and they cause this kind of chronic GI bleed. So think third world countries really for this one, because we don't see this so commonly anymore in the United States. Heavy menses can cause blood loss. We talked about the fibroids and that part of our differential. GI cancers or GI bleeds can cause a chronic bleed, which can lead to iron deficiency anemia. If you have a vegetarian or vegan diet, iron is very common in muscle protein. And so that's something, you have a vegan or a vegetarian diet, you may have to supplement with that. If somebody's had a colectomy where they've taken out part of their bowel, they may have an impaired absorption of that iron. Or increased erythrocyte demand, somebody who's pregnant, that blood is getting shunted to the fetus. And so they may get iron deficiency anemia early on in that pregnancy is very common. Let's go over our labs. We know CBC, this is part of the same thing that we just talked about. Decreased MCV, decreased MCHC. On smear, we're going to see microcytic hypochromic cells. If we're going to order our iron studies, because we're thinking it could be iron deficiency anemia, remember we've talked about these twice now. The TIBC will be elevated, will have a decreased serum iron and a decreased ferritin. They may also have a positive stool hemoccult if they have a GI bleed. So remember on these type of questions, don't ever forget to rule out GI cancer. If they have a positive hemoccult or they're late on their colonoscopy, always order a colonoscopy to be extra sure. Treatment for this is proper diet. You can give ferrous supplementation, and you usually need about a year of supplementation for this to get back to your normal levels. So make sure you know this one, it's commonly tested. Our last one in our microcytic hypochromic anemias are going to be Citroblastic Anemia. Citroblastic anemia, what happens is the body is unable to incorporate the iron into the heme, so it causes the erythrocyte to be deficient in heme. The most common cause of this by far is lead poisoning. So think about if the patient presents, they moved into a historical home, they have lead pipes in their older home, they may have lead paint, the baby's eating the paint chips, falling behind in school and developmental delay. This causes neurological dysfunction with chronic exposure to lead. Ataxia, again, there's neurological deficiencies in sideroblastic anemia because of the lead. Lead lines, if you look at their gums, they have this kind of thin black blue line at the junction of the teeth and the gingiva. So that's lead lines you may see on the physical exam. So by far, lead poisoning is the most common cause of this, but this can also be due to myelodysplastic syndrome, deficiencies in B6 and copper, chronic alcoholism, zinc overdose. If somebody's taking over-the-counter cold remedies, we see that a lot in Zicam is one of them over-the-counter. Tuberculosis medications and chemotherapy. Again, all of those are very rare. Really focus on the lead poisoning for the causation of this one. Workup for the labs. We know this is part of our microcytic hypochromic. So decreased MCV, decreased MCHC. Smear, we're going to see the microcytic hypochromic and basophilic stippling on this one. Again, that's that second picture down here. You're going to do a heavy metal screen, which will screen for both lead, copper, and zinc. And remember, those can cause this as well. Bone marrow biopsy, you'll see something called a ringed sideroblast. And if you look at that top picture there, it looks like you have kind of sprinkles around the side. It's called the ringed sideroblast. It looks like you kind of have sprinkles in the cell. This is iron clumps in the mitochondria that cannot be incorporated into the heme. And then finally, on long bone x-ray, we can see on this bottom picture, you have these kind of dense metaphyseal lines on there. And so that's something very specific to sideroblastic. The treatment for this is you want to identify the source of the lead exposure and stop that exposure. If they have a B6 deficiency or copper deficiency, you want to fix that. And if it's a myelodysplastic syndrome, you want to do a bone marrow transplant, but really focus on lead poisoning as being the causative reason for sideroblastic anemia. All right, so those are the three of our microcytic hypochromic anemias. Remember, the factory is working, but we just have a deficiency in the red blood cell building blocks. Now we're going to do our normocytic anemias. Remember, this is where the bone marrow or the factory is not working properly, and so we get a deficiency in our red blood cell numbers. The three types that we'll talk about are anemia of chronic disease, aplastic anemia, and our myelodysplastic syndromes. Anemia of chronic kidney disease. Chronic kidney disease is something that's commonly associated with anemia in its later stages. So in the question, expect that they're going to drop something about this patient having a chronic comorbid kidney disease. Also, easy bleeding may be in the history of this one. Because they have easy bleeding, you may also see ecchymosis on this patient. The etiology of this in chronic kidney disease, there's decreased erythropoiesis, so we're not making enough red blood cell. We'll also have a deficiency in serum iron, a decreased erythrocyte lifespan, so they're being killed off quicker, and an increased hepcidin. Hepcidin prevents the iron to be absorbed in the red blood cell, and it prevents the release of stored iron. So there's a lot of things going on here. We also have an increase in cytokines, and the cytokines destroy the little baby red blood cells, the reticulocytes. And then eventually we also develop fibrotic bone marrow. So there's a whole spectrum of things that are going on here that contribute to the fact that anemia is due to chronic kidney disease. Most common for this is going to be our African American population, just because there's a higher incidence of chronic kidney disease in that population as well. Remember that anemia is the result of chronic kidney disease. So it's usually somebody over the age of 60, because this is not something that just happened overnight. Our CBC, we're going to see a decrease in reticulocyte. Those are the little baby red blood cells. Decrease in platelets, another reason why they have easy bleeding, and a decrease in red blood cell, hence the anemia. On smear, you may see a special cell called an echinocyte that you can see in the picture here. Echinocytes happen because there's a higher water permeability of the erythrocyte membrane, so they get this kind of spiky appearance to it. On CMP, findings that are common in chronic anemia, hyperkalemia, hypocalcemia, an increase in your BUN to creatinine ratio because we know we're in kidney disease. Iron studies are interesting for this one. It could be normal or abnormal. So don't get kidney disease confused with just straightforward iron deficiency anemia. So we could be normal or abnormal. It could be due to malnourishment, removal of the iron from dialysis, comorbid iron deficiency anemia, and increase in our hepcidin. That could cause all of the iron studies to be abnormal or normal, just depending on all of those characteristics there. If we wanted to figure out, is this definitely from renal disease, we could do a renal ultrasound or MRI, or a bone marrow biopsy if it's later in that, if we think that they're developing fibrosis of that. Treatment for this is erythropoietin stimulating agent. We want to kind of whip the body to make more red blood cells. And those are some of the brand names that you'd see. So Epigen is an example, Procrit is an example. Those are some of the common agents that they use to stimulate that red blood cell production. So kind of in summary, for your exam question, they'll give you the hint that they have chronic kidney disease, either by telling you that they have it, or your BUN to creatinine will be off. And so that's kind of something where you should be thinking, okay, it's not just straightforward iron deficiency anemia. Next, we have our aplastic anemia. Aplastic means no growth. In this is a life-threatening pancytopenia. So the entire factory shut down. You're not making anything. This is due to the destruction of the bone marrow stem cells. So in this one, they're going to present usually with some type of recent infection because they're not making any kind of white blood cells at all. So recent infection, petechiae, gingival bleeding, and bruising because they don't have enough platelets. So again, life-threatening pancytopenia because we have a destruction of the factory itself. The bone marrow stem cells have shut down. This can be autoimmune. So cytotoxic T cells can kill off that stem cell growth. This could be congenital, something called Fanconi anemia that we'll talk about. This could be due to a viral infection, hepatitis, Epstein-Barr, HIV, parvovirus B19. Remember, parvovirus B19, we talked about this one in our dermatology unit, Fifth's disease. Parvovirus B19 can cause an aplastic anemia. Environmental toxins like benzene can cause this, and then radiation, some kind of radiation to the bone marrow. Typically, this is an older population, so over the age of 60. On CBC, we're going to see a pancytopenia. Everything is low. We'll also see a decrease in the reticulocytes, the red baby blood cells, because the factory is not working. On smear, we may see the specific cells called those dacryocytes. They kind of look like a tear shape. On bone marrow biopsy, this is going to be definitive for this one. We'll see a decreased number of stem cells. So a definitive test is a bone marrow biopsy. The way we treat this, transfusion, stem cell transplants, immunosuppressants if it's due to an immune cause, and then hematopoietic growth factors. We want to stimulate them to start producing those cells again. So that's aplastic anemia. Next, we'll talk about our myelodysplastic syndrome. So we have myelofibrosis and myelodysplasia. In both of these, a lot of these have to do with just the fact that this factory is being shut down for some reason. It's functioning improperly. In myelofibrosis, they typically have a history of cancer because it's caused by metastatic cancer. Both of these can cause petechiae, gingival bleeding, and ecchymosis, and that's in relation to those platelets being decreased. So history of cancer, think myelofibrosis. This is a fibrosis of the bone marrow and destruction of the stem cells from metastatic cancer, most commonly lung, breast, and prostate. When we do an aspiration of the bone marrow, we'll see that there's no cells, there's nothing growing. On the bone marrow biopsy, you'll see these very deformed and anaplastic cells. And then on smear, you may see that dacryo, that tear-shaped cells, dacryocytes, giant amorphic platelets, and then blasts, which are kind of lazy teenager cells. They don't really do what they're supposed to do. For the myelodysplasia, this is a myeloid stem cell dysplasia. And this one, here's your key point about this one. This is a precursor to acute myelogenous leukemia. That's going to be your exam question on myelodysplasia. Myelodysplasia is a precursor to acute myelogenous leukemia. This can be idiopathic, radiation exposure, environmental exposures to things like insecticides, benzenes, or due to a viral infection. On CBC for myelodysplasia, we're going to see that pancytopenia, everything is decreased. On smear, there's a special cell for myelodysplasia, Dole bodies. These are remnants of rough endoplasmic reticulum within the cell. On the bone marrow biopsy, we're going to see all of these dysplastic amorphic cells, and again, lots of blasts, these kind of lazy, non-functional teenager cells, as I like to call them. Both of these are going to be treated by referral to oncology. So again, this is kind of where we say, okay, as PAs, we can treat this if we're in oncology, but for more of a general perspective, for something like this, I would refer to oncology for that. All right, so that was all of our normocytic anemia. So now let's do our macrocytic anemias. Remember, the factory works, but we have a vitamin deficiency for the red blood cells. So the three types we'll talk about here: vitamin B12 deficiency, folate deficiency, and anemia of chronic alcoholism. Let's start out with the B12 deficiency anemia. Pernicious anemia is a very specific type of this. So let's talk about the history first. Very common history findings, and this one is very commonly tested on the boards as well. Sore tongue, peripheral neuropathy, and this one is very important. B12 deficiency anemia is differentiated from folate because of the neurological differences. So B12 deficiency will cause neuropathy, dementia, decreased vibratory sense and proprioception where you are in time and space. So remember, neurological defects is going to be B12. Not neurological defects will be folate. Weakness, taste, and smell disturbances can also be associated, but not as common as peripheral neuropathy and dementia. Physical exam findings are going to be very similar for B12 and folate. Glossitis, swollen tongue. Lemon yellow, waxy skin pallor. This is a very specific sentence, but it's really important. Lemon yellow, waxy skin pallor. Remember, with B12, we'll have those neurological findings. So decreased vibratory sense. Ting, you take a tuning fork and put that on a bony prominence, and they won't be able to feel the vibratory sense. Proprioception, you can orient their big toe upwards and downwards, ask them to close their eyes and tell you which way it's oriented, up or downwards. That's a good way to test proprioception. Vitamin B12 is required to make the erythrocyte DNA. This will develop over years. This one takes a lot longer to develop than your folate deficiency. Things that we know can cause this: dietary causes, things like vegetarians need to usually supplement B12. Somebody who has a malabsorption syndrome, they had a gastric bypass, or they're an alcoholic, or they have inflammatory bowel disease like Crohn's or ulcerative colitis, or pancreatitis, they're not absorbing that vitamin B12 as well. Pernicious anemia is a specific type of B12 anemia. This is an autoimmune destruction of the parietal cells. Parietal cells make intrinsic factor, which is required to absorb that B12. That's really highly tested on the board, so I'm going to say that again. Pernicious anemia is the autoimmune destruction of the parietal cells that make the intrinsic factor that is required for B12 absorption. So it's a specific type of autoimmune B12 deficiency anemia. Our labs for this unit, these little three here: CBC, they're going to be large. Remember, these are macrocytic, so MCV is going to be elevated. On smear, we'll see macrocytosis, they're enlarged. This is also a megaloblastic type of anemia, which means our granulocytes are hypersegmented. They have lots of little different poles in there. Howell Jolly bodies, remember we talked about those. Those are kind of the little purple dots in the cell. That's remnants of the DNA in the nucleus. Decreased serum B12, that's pretty diagnostic for this one. Elevated methylmalonic acid and homocysteine. Let's go through this one carefully. Both methylmalonic acid and homocysteine require B12 for their enzymatic conversion to other substances. In the absence of B12, they can't be converted, so they start to elevate and elevate and elevate. So in B12 deficiency anemia, you'll have an elevation of both methylmalonic acid and homocysteine. Hold that thought until we get to the next slide. You may also have intrinsic factor and parietal cell antibodies if you have pernicious anemia. That's a lab that you can order. The Schilling test, I'm only going to mention this. I don't even think this is on the boards anymore. It's a pretty antiquated test. It differentiates the cause of B12 in the urine by measuring B12 in the urine. We don't really use that anymore because we have much better testing now. The way that we treat this is we supplement B12. And here's your trick on the boards: is they're not going to give you vitamin B12 as the answer. They're going to ask you what the chemical name is. So cyanocobalamin is the chemical composition for B12. If you treat this with folate, the neurological symptoms will worsen. And that's an important point. If you're like, well, folate is much more common, why not just treat it with folate and see if they get better? Their neurological dysfunction will worsen. And that may be a little key in the board question or the exam question that they tell you somebody mistakenly treated this with folate and their symptoms got worse. So that's B12. Make sure you know that one. That's really highly tested. Now let's do folate deficiency anemia. This one is much faster in development. So this is weeks to months rather than years. The history on this one is kind of nonspecific: weakness, sore tongue. Physical exam finding is very similar to our B12. So glossitis, same. Lemon yellow waxy skin pallor, same. The biggest difference here is there's no neurologic deficits with folate deficiency anemia, and that's key here. So no decreased vibratory sense, no decreased proprioception. Folate is vitamin B9. This is required to make erythrocyte DNA. So again, this is one that develops faster, so it's more common, develops over weeks to months. Dietary causes of this: overcooked food. So if you microwave those foods, it kind of robs the nutrients. Lack of leafy greens, citrus, and legumes. That's where we commonly see folate. Malabsorption, same thing as B12, gastric bypass, alcoholism, inflammatory bowel disease, and celiac disease. Some medications can increase the likelihood for folate deficiency anemia. Metformin that we use for diabetes, sulfa in antibiotics, and anti-epileptic drugs can increase the likelihood for this. Patients who are on dialysis can have folate removed from the bloodstream. And then increase in erythrocyte demand. So in pregnancy or in hyperthyroidism, you are needing more red blood cells so you can run out of the folate while you're trying to make them. This is much, much more common than B12 deficiency because it happens much faster. Labs are going to be similar. So increased in MCV, we know this is a big one. So macrocytosis, also megaloblastic, hypersegmented granulocytes, the Howell-Jolly bodies, same thing as B12. Decrease in serum folate, pretty diagnostic for this one. I wanted you to hold that thought about the homocysteine and the methylmalonic acid because I want to make this point here. You'll have a normal methylmalonic acid, but still have an elevated homocysteine. That's another way that we can differentiate these two. Only homocysteine requires B12 and folate for conversion. So if you lack the folate, you will still have an elevated homocysteine, but methylmalonic acid only needs B12 in order to be converted. So methylmalonic acid will be normal, homocysteine will still be elevated because it needs both folate and B12 in order to be converted. We treat this with folic acid. The recommendation is about 400 micrograms daily. So there's B12, folate. Remember, B12 takes longer to develop, folate more common, but you don't want to accidentally treat B12 with folate because that will worsen their neurologic deficits. Lastly, we have the alcoholism-associated anemia. This one we can gauge what their level of alcoholism with our CAGE screening. Thought about cutting back. Are you annoyed when people criticize you about drinking? Do you have guilt about drinking? Do you need an eye opener, which is a beer or a shot first thing in the morning? Determine how many drinks per day and for how many years. And that will be, again, dropped to you in the question is if they have an anemia, they will kind of hint to you that this person has had alcoholism. The physical exam findings that we see here are not specific to the anemia. They're associated with chronic cirrhosis. So gynecomastia, because we have a buildup of estrogen in the bloodstream that's not filtered out. Jaundice, hepatosplenomegaly, and ascites. So you can see the jaundice is that yellow coloration of the skin because they cannot get rid of the conjugated bilirubin. Ascites is this buildup of fluid because they have a blockage in that portal venous system because their liver is cirrhotic. The etiology of this: alcoholism causes cirrhosis. Cirrhosis causes poor erythropoiesis. They're not making enough red blood cell, and it decreases the red blood cell lifespan. That's why they get jaundice, because they have this hemolysis. More common in males, just because alcoholism is more common in males. On CBC, we will see an anemia, a thrombocytopenia, and remember that MCV is going to be elevated because this is in that the megaloblastic one, or excuse me, the macrocytic one. On smear, this is going to be macrocytic, but not megaloblastic. So megaloblastic, remember, they have those hypersegmented granulocytes. This one does not have this. In addition, your liver function tests will be elevated. So they'll have an elevated AST, ALT, depending on where they are in the progression of that alcoholism. How we treat this is we treat the cause. We want to treat the alcoholism to slow the cirrhosis progression. So we would refer them either to an Alcoholics Anonymous or consider a detox facility. So you're really treating the cause of the anemia in this one. So those were our three main categories. If you can remember which one goes in each category, that way you're not just memorizing the labs, you understand why they are the way they are. Now we're going to talk about some hemolytic anemias. Remember, in our hemolytic anemias, the factory is working, but the red blood cells are exploding. You're having this hemolysis, our little fireworks going on in our little red blood cells here. The first one that we'll talk about is sickle cell disease. This is a genetic disorder where the hemoglobin is abnormal and it sickles in hypoxic events. So let's talk about the history first. Ischemic bone pain and abdominal pain during their hypoxic crisis. They are at much higher risk for thromboemboli, so a CVA, stroke, or a pulmonary embolus. They're also at increased risk for cholelithiasis because they have this increase in bilirubin from the hemolysis, which causes this kind of sludge in the gallbladder. They are also at higher risk for pulmonary hypertension because they get this inflammatory process. This decreases nitric oxide and causes pulmonary vasoconstriction. So they will eventually develop pulmonary hypertension. They are also at higher risk for renal failure because the sickled cells will damage the nephron in the kidney. Cardiomyopathy is also common in patients with sickle cell disease. They develop left atrial dilation and diastolic dysfunction. Right now, we are not sure what the cause of that is. They are also at higher risk for osteonecrosis of the femoral and the humeral head because you've got those little tiny blood clots and it occludes the blood supply to that area. During their hypoxic crisis, jaundice, splenomegaly, because they're chewing up all of those abnormal cells, and bone marrow hyperplasia. So they get frontal bossing, they get an enlarged forehead and a large maxilla. So those are some bony deformities associated with sickle cell disease. Again, this is abnormal hemoglobin. If you look at these pictures here, you can see that they get this kind of sickle cell instead of that normal biconcave disc. And this causes a blockage in the arteries, causing ischemia, infarction to the downhill tissues or the downstream tissues. This is an important point. If they only have one copy of this gene, their genotype HBS, this is the trait only. The red blood cell do not sickle, but they are resistant to malaria. So sickle cell is one of those really interesting diseases where evolutionarily, this was preventative as far as getting malaria. So if you have just the trait, you are resistant to malaria, but you don't have the hypoxic crises. If you have both copies, so hemoglobin SS is your genetic karyotype, you have both the disease and you are resistant to malaria. It's really important that a lot of the board questions will say, oh, if they just have the trait, how do we manage this patient? And that's kind of a trick question because the answer is nothing. They don't get the disease, they don't get the hypoxic crises. Crises can be triggered by any kind of physiological stress. So extreme cold, hypoxia, infection, dehydration, alcoholism, stress, or pregnancy. So those are all precipitants for the crises. This starts at 4 months old because the fetal hemoglobin does not sickle. And this is key to one of the treatments for this. So you transition from a fetal hemoglobin to the adult type of hemoglobin at 4 months. That's why less than 4 months, we don't see this. This is very highly common in the populations, the ethnicities, African American, Middle Eastern, and Mediterranean. It's in fact the most common inherited blood disorder in the world. On CBC for this, remember this is a hemolytic type of anemia. So we'll see a decreased hemoglobin and hematocrit during our crises. We may also see a thrombocytosis. On the smear, we're going to specifically see sickle cells. So don't expect that to be a question is, what do you see on the smear of a sickle cell patient? That's not going to be a question, but sickle cells, target cells, and Howell Jolly bodies. Those are 3 specific types of cells that we can see with sickle cell anemia. Remember that our definitive test for this, because it is a genetic disease, is a hemoglobin electrophoresis. So that's your answer choice to the test question. During the crisis, it's important to get a chest CT to rule out pulmonary embolus and a brain CT to rule out a cerebral infarct, so a stroke. During the crisis, we want to treat them symptomatically, so reduce any kind of physiologic stress through fluids, provide them oxygen, opioids for the pain, because this is a very painful crisis because they're having ischemia, and then prophylactic antibiotics. If you're treating them chronically, hydroxyurea is the mainstay therapy for this one. And what hydroxyurea does is it increases the amount of circulating fetal hemoglobin, because remember that fetal hemoglobin does not sickle. Sickle cell, very commonly tested on your boards. Next, we're going to talk about G6PD anemia. This is an X-linked genetic disorder. So it's an X-linked deficiency in glucose 6-phosphatase dehydrogenase and catalase. These are enzymes that destroy free radicals. Free radicals are toxic to erythrocytes. So we are lacking the Army and the Navy per se to protect our erythrocytes. This causes an acute hemolytic anemia only during a trigger. In the history of a G6PD patient, they typically have prolonged neonatal jaundice because that's a stressful time period. Being born is very stressful, and so they'll have an increased hemolysis during that time period. So that leads to a neonatal jaundice. Here's where the question is going to probably be, is they're going to have a trigger because they took dapsone, sulfa, quinine, chloroquine, quinolones. These are all anti-malarial medications. So they are going on some kind of trip where they are taking prophylaxis for malaria and they develop this hemolytic anemia. That's usually how the test question is set up for you. So look for dapsone, sulfa, quinine, chloroquine, quinolones, red wine, legumes, tonic water has quinine in it, and fava beans. Fava beans are very particular to Mediterranean diets. They have oxidants in them that release hydrogen peroxide. Hydrogen peroxide is cytotoxic and requires catalase to break it down. Well, we don't have any catalase in G6PD anemia, so that's how fava beans can trigger this. So very specific triggers in these questions. They may eventually develop splenomegaly after a while of having this, if they're having chronic episodes, because again, remember that's chewing up all of those hemolyzed red blood cells. Jaundice will only occur during that severe hemolytic event. Otherwise, they are normal. So without that trigger, they are normal. Once they have the trigger, they develop this hypoxic event, they get jaundice, they get all of this hemolysis going on, again, because they lack the catalase and the glucose 6-phosphatase dehydrogenase. Much more common in these populations, African, Middle Eastern, Asian, and Mediterranean ethnicities. On CBC, we'll see an anemia because this is a type of anemia, and reticulocytosis. The body is trying to compensate for all the red blood cells that are being broken down by making little baby red blood cells. On the smear, Heinz bodies are a specific cell type that we may see in this disease. These are clumps of denatured proteins within the erythrocytes. Definitive for this one is going to be a G6PD genetic assay. And you may also see during that event that they have a transiently increased unconjugated bilirubin. But again, that goes back to normal if they're not having that. So our definitive test for G6PD anemia is going to be that genetic assay. Treatment for this, avoid the triggers. Don't take any anti-malarial medications. Don't take sulfa antibiotics. Don't eat fava beans. So avoid our triggers. Next is PNH, or paroxysmal nocturnal hemoglobinuria. If you look at that picture there, that's Coca-Cola urine. That's what their urine looks like. For the history of this patient, it's pretty specific. Their first morning urine is going to be a very dark coloration. This is a genetic mutation of the PIG-A gene, P-I-G-A gene. It collects in the bone marrow. It causes premature erythrocyte breakdown. So all of this hemoglobin collects in the bladder overnight and makes it very, very dark. On CBC, non-specifically, you may see reticulocytosis and anemia. That's pretty common with a lot of these hemolytic anemias. Increased sensitivity to complement causes lysis of the cells. Remember, these cells are very fragile and they break down very easily. Positive urine hemosiderin. These are the components of the red blood cell breakdown. So you'll see urine hemosiderin. Decreased free haptoglobin. We know that everything that's hemolytic will have a decreased free haptoglobin because that binds the hemoglobin from the lysed red blood cells. Flow cytometry is a test that we can use to determine how many of these cells are affected by this so that you can figure out how many cells are being lysed. We treat this with a medication that's an anti-complement antibody. So it protects that complement. And then bone marrow transplant could be more definitive for this if they're not responding to that monoclonal antibody drug. Infectious mononucleosis, we'll talk about this in several of our units here. In infectious mononucleosis, this is an Epstein-Barr virus of the B lymphocytes. That's really important. Epstein-Barr virus of the B lymphocytes. This is much more common in our young adult population. We call this the kissing disease because you can get it from kissing, sharing food, sharing drinks. Extreme fatigue in the history, extreme fatigue, very sore throat. You can see on that top picture, that's probably why they have a sore throat there. History of sharing drinks or food or kissing. On exam, cervical lymphadenopathy. You look in the back of their throat and they have these tonsillar exudates. You could also think about strep in this situation as part of your differential because that can kind of look like that too. So tonsillar exudates, splenomegaly, depending on how severe it is, because all of those cells are being chewed up by the spleen. This is a really important point that I'm going to come back to when we get to the counseling points on this. Jaundice may occur. They may have a faint transient rash or a palatal petechiae on the inside of their mouth. On CBC, we're going to see a leukocytosis. On smear, we will see atypical lymphocytes. Look at that second picture down there. So these are kind of dysmorphic lymphocytes. So atypical lymphocytes can be definitive for this. The definitive test that you can do in the clinic is called the monospot test, but they won't ask you that on the boards because monospot is a brand name. So the heterophile test is how we do this. And the heterophile test is a blood test that's done in clinic. They may also have an elevated IgM, but the heterophile test is a really good screening test in the clinic. Treatment for this is supportive. Anti-inflammatories, rest. This can take a long time to go away. So self-resolve in about 10 days to 3 months. Here's the important counseling point. No contact sports because that spleen is enlarged and it's easier to rupture and you can bleed out and die if you have a ruptured spleen. So avoid any kind of contact sports with mononucleosis because of the risk of splenic rupture. Another interesting point, and this is more for practice, if you mistake this and you give them, you think, oh, well, it's probably strep, and they get penicillin antibiotics, they will actually get a rash because they're reacting to that because this is not a bacterial infection, it's a viral infection. Next, we have spherocytosis. Spherocytosis is a genetic defect where they develop these sphere-shaped cells, sorry, that's hard to say, instead of the biconcave disc. So you can see the normal erythrocyte over to the right there, and then you see the spherocyte. Because there's a defect in the membrane that causes early destruction and decreased lifespan of these red blood cells, so they're constantly having elevated hemolysis. You can develop cholecystitis from this because they get excess unconjugated bilirubin from the hemolysis, and this causes bile sludge, which can lead to gallstones. They can also develop icterus in a stressful situation, which is jaundice of the eyes. So splenomegaly, because that spleen is chewing up these abnormal red blood cells, and jaundice can be physical exam findings for these. On CBC, you will probably see a normal red blood cell. You'll see an MCHC that's increased because these are darker type of cells. You can see on that picture there that the spherocytes that are in the circles, they are a darker type of cell. On the smear, it's going to be specific for the spherocytes. Here's the definitive test for this one besides the smear test. Abnormal osmotic fragility test. Because there's a defect in that membrane, osmosis is not going to be normal. And so they'll be much more fragile and susceptible to either getting big or getting small. LDH is going to be increased because this is a hemolytic anemia, and then they're going to have a decrease in free haptoglobin because it's a hemolytic anemia. Remember, not just memorizing the test, but understand what they do. Treatment for this, if it's very severe, can be a splenectomy or taking out the organ that's chewing up these red blood cells. If they develop cholecystitis, you can do a cholecystectomy. So it depends on the severity of this. If they're developing splenomegaly, you can take it out. If it's not and it's mild, you don't really have to do anything. Fanconi anemia. I mentioned this one when we were talking about congenital forms of aplastic anemia. In Fanconi anemia, this is an autosomal recessive defect in a lot of the DNA proteins. So there's a lot going on with this. It's not just the anemia for this one. We're looking for a family history in this because we know it's genetically inherited, and it's much more common in Ashkenazi Jewish populations and South African populations because of their ethnicity. Physical exam findings that we may see in Fanconi anemia, cafe au lait spots. We talked about this one in our dermatology. That's the top picture there. Spina bifida, epicanthal folds is the second picture down there. Microcephaly, they have a smaller head. Dangling thumbs, hip dysplasia, clubfoot, abnormal genitalia, and gastrointestinal malformation. So there's a whole spectrum of things that goes along with Fanconi anemia. On CBC, you'll see a pancytopenia, because remember, this can cause that aplastic anemia. Amniocentesis, so this is going to be a genetic test for this. And again, that's if they have that family history. So increase in chromosome breakage, and then a genetic analysis, because we know this is genetically inherited. We're going to try to stimulate the production of red blood cells with our hematopoietic growth factors, and then eventually stem cell transplant. Erythroblastosis fetalis, or hemolytic disease of the newborn. This is due to a mismatch between the fetal and the mother RH status. So a history of stillborn or miscarriage. This is important because it's the first pregnancy that sensitizes. So they don't have any issues the first pregnancy, but it's the first pregnancy that sensitizes. In the baby, if they're born with this, prolonged jaundice, but this is usually something that we know due to our routine screening during pregnancies and the RhoGAM shot, which I'll talk about. If this is very severe, you can develop hydrops fetalis, which is this widespread, massive systemic edema that usually kills the fetus. This is an emergent disorder that must be treated very quickly in order to save the life of the baby. This is where the maternal antibodies attack the fetal erythrocytes. This is an ABO or an RH incompatibility. Here's your board question here. What's the most likely cause for this? This is going to be an RH negative mom and an RH positive father, because this is causing an RH positive fetus. So RH negative mom, RH positive dad increases the likelihood that that will be an RH positive fetus. So RH negative mom, RH positive fetus. That first pregnancy will sensitize the maternal antibodies towards this. This happens in 10% of all pregnancy, and it's usually male fetuses for this. So if that baby is born and we didn't know that they had this, their hemoglobin will be less than 4. They're having massive hemolysis. The way we test for this is that indirect Coombs test that I mentioned on that second slide. So that's really where that indirect Coombs comes in, is mother fetus ABO incompatibility. We treat this as that baby's born with IVIG and blood transfusion. We try to prevent this with the RhoGAM shot. All RH negative mothers are given the RhoGAM shot at 26 to 28 weeks for prevention, regardless of the reported father or the reported pregnancies, because it's very likely that they had a miscarriage that they didn't know about. So even if they say, well, I've never been pregnant before, we still give that RhoGAM. And regardless of who they say the father is, you still give the RhoGAM, because there can always be oopsies there. So every RH negative woman gets the RhoGAM shot. If the newborn is Rh positive and they have an Rh negative mother, RhoGAM is also given within 72 hours after delivery. So biggest summary for this slide, what are you going to be asked a question on, is Rh negative mom, Rh positive father puts it at higher risk for Rh positive fetus. Malaria and other bloodborne parasites. So this is our hematology unit. We'll also discuss this one when we talk about our infectious disease unit. In malaria, the patient will have these cyclical fevers every 48 to 72 hours, high fever, shaking chills. This is a plasmodium that's transmitted through the Anopheles mosquito that causes a hemolytic anemia. And this is for people in tropical areas that we typically see this. We can treat this with an anti-malarial unless you have G6PD anemia, and then you can't. So chloroquine, quinine, doxycycline, and Malarone are the treatment for this. And that top picture is the Anopheles mosquito. Babesiosis, this is Babesia microti, and this is transmitted through a tick. This can cause shaking chills and a hemolytic anemia. The most common tested question about babesiosis is the Maltese cross that you can see in the second picture down there. That is a formation that occurs in the red blood cells. Chagas disease, or Trypanosoma cruzi. This is through the kissing bug, and that's the second picture there. It kisses, it bites on the lip. So you get the shigoma, which is in the picture over there to the right, and ipsilateral eyelid edema on that side. That can lead to chronic cardiac and GI problems. Finally, we have Trypanosoma brucei. Brucei, this is through the tsetse fly. That's tsetse is not TSE, tsetse fly. This can cause fever, occipital lymphadenopathy, and fragmented sleep. That's why it's called African sleeping sickness. So these are all bloodborne parasites that we may see in this hematology unit, excuse me. The way that we diagnose all of these is through a smear. And on the smear, you're going to see the parasites. Look at the bottom part there for the trypanosoma and then the Maltese cross. That's what we have for part 1. Hopefully you will join us for part 2. If you're interested in learning more, there's 2 options. If you're interested in just the rest of the review video and the deck of slides, you can purchase that. Or if you're interested in the extra materials where you can take a practice test, you can do a clinical pearls matching exercise, the links are in the bottom descriptor part of the video. I just want to show you real quick some of these extra materials. This is the clinical pearls matching exercise. It's a drag and drop, repetition, repetition, repetition. So you see the most commonly tested things about that disorder on the left, and then you have your drag and drop menu. We have a level that's kind of at the didactic level. So it's a moderate level difficulty. It's not as challenging as the board questions so that you can kind of work up to that. It helps to tell you what's really important in that stem. You'll see that in all capital letters. So what is the mechanism of action? So you know what you're looking for in that question. There's 4 answer choices for these, and anything that you are answer incorrectly will be emailed to you so that you can review that for the actual test. We also have a board level, so a PANCE or PANRE. This is a much more challenging level of question, and there's 5 answer choices. Again, you'll get the email sent to you so you can study all of the things that you answered incorrectly. Thank you for watching. I hope that this helped. Please see the rest of the videos in this series. Again, this is not designed to be medical advice. It's for educational purposes only. All of our photos are attributed through the Creative Copyright Commons for those photos. And all of our sources are cross-referenced with evidence-based medicine sites. So thank you for watching, and I'll see you for part 2.